So they now that brings us to the management aspects, and we will be mostly dealing with that tomorrow. And all of us know that the cornerstone of management in stomach cancer is surgery, and even nowadays, majority of the Japanese surgeons, they would agree, they would prefer to go for surgical management, even if it is advanced stomach cancer. In this way, they little bit differ from the European group, and they are doing their own trials now in Japan, and almost at the end of the trials to decide whether adjuvant perioperative chemotherapy, which is a norm in European subjects, now is it true for Japanese or not? So surgery is still the main part in the management of stomach cancer, and in different surgical procedures, the basic is the gastrectomy, the resections of the stomach in different forms depending on the situation or the extent of the disease. And like any other surgery in GI tract, there is a debate regarding the minimally invasive versus the open surgery. Slowly and steadily, and I must agree that minimally invasive surgery is taking over in many areas in the management of GI tract cancers, and stomach cancer would be one of them. So now we would only discuss about the minimal invasive surgery related to gastrectomy per se. And I think I'm not very sure whether he would deal with Dr. Hamza Wani from GMC Jammu, the other part of the Jammu Kashmir. He would be discussing about the minimal invasive surgery, minimal invasive gastrectomies. Possibly he will be covering the benign or malignant, and if he only covers the malignant part also, it's okay. So, Dr. Hamza Wani, please continue your talk.
Thank you very much, sir.
Before Hamza starts, I forgot to mention, I'm sure Das may have mentioned, Nisar also is our former fellow from SGPGI.
Yes.
And I'm very happy to see Das and Nisar, they are the first generation fellows. I'm very happy to see the second generation of fellows now, because Hamza has done his fellowship with Dr. Ibrar, who was our fellow in SGPGI. So I welcome the second generation, the grand fellows now to Masterclass. Hamza, please.
Thank you. Thank you very much, sir. Very kind of you. I'm probably the junior most colleague over here. So youngest. I would like to...
Don't say junior most, youngest, most energetic.
Thank you, sir. So the ambit that was given to me was minimally invasive techniques for gastrectomy. And sir told me to focus on the literature and the current status of gastric carcinoma. So I'll be focusing on the malignant disease itself. So is my screen visible, sir?
Yes.
Yeah. So just an overview, we know that CA stomach is the 5th most commonly detected malignancy and 3rd largest cause of cancer-related death. Like we discussed before, it is one of the 3 largest burdens of malignancy in our region, that especially the Kashmir division of the state. Now, when we look further east, the other part of the coin is the Southeast Asian countries, particularly Korea and Japan, having a robust screening programs detect early gastric carcinoma, and it takes about 61% of their diagnosed burden. And the majority of our cases are detected at stage 3 onwards, and stage 2 if we are very lucky. So talking about adenocarcinoma of the stomach, there are 3 main determinants of the disease. First is the stage, then the general condition of the patient, the performance status, as well as any comorbidities, and the tumor location. Why do we talk about the tumor location? And this is because it actually determines the kind of surgery your patient is going to have. For adenocarcinoma of the distal and middle third of the stomach, you would have to subject the patient to something of a subtotal or a distal gastrectomy with any reconstruction, any variation of the Billrod 2 or a Roux-en-Y gastric anastomosis as per the surgeon's choice. For proximal lesions, those having linitis plastica, poorly differentiated tumors of the diffuse variant, total gastrectomy is the procedure of choice, and a reconstruction will entail an esophagogynostomy Roux-en-Y. It is important to mention because when we talk about minimally invasive surgery, these are the techniques and the procedures that you need to replicate in the OR. The next most important part of the gastric resection is the lymphadenectomy. I won't go much into it. It will be discussed tomorrow. But we need to map the route to R0. And the Japanese Research Society for Gastric Cancer has been telling us from the 70s about the nodal stations from 1 to 12, which are relevant in gastric carcinoma. And how do we talk about D1, D1 plus, and D2? What to do when and how? But I'd like to specify here that it does affect disease specific and overall survival. So it is a very important part of our surgical practice. Now, particularly talking about minimally invasive gastric surgery, if we talk about a lesion in the distal or middle third of the stomach, the specimen inside would look something like this. Once we enter the lesser sac, retract the stomach cranially, the stations labeled in blue would entail a D1 block. Once, if we include 8A and 9, would be a D1 plus. And if we take the proximal sphenic artery nodes and the proper hepatic artery nodes, it would be a D2 resection. So this is just to give an idea that where do we need to go and where from the pedicles need to be taken in the view of a minimally invasive scenario. Also, when we talk about minimally invasive surgery, the concept of the mesogastrium that came from China and dissection in the enjoyable embryological space, as Dr. Das sir was making a comment earlier, where do we need to dissect? So there are 6 main mesogastric pedicles that have been described, anatomic pedicles. They are the left and the right gastroepiploic mesogastrium, the left and the right gastric artery arterial mesogastriums, and the posterior gastric mesogastrium that is along the sphenic artery. So by a combination of exposure, traction and counter traction, separation of the embryological planes, dissection at the root, and ligation at the root, we can actually get rid of the lymph node block along with the lymphovascular components along with that. So that would entail the basic principles of a standard gastric D2 resection in a minimally invasive settings. So whenever we do an open radical distal gastrectomy, this is what we are looking at post-dissection. What we want to see is a completely bare tumor bed where you can see the celiac axis, the proximal part of the sphenic artery, the station 8A node taken, the 12A node gone, and ligation of the gastroepiploic vessels at the root at the base of the pancreas. Now, how do you translate this triad into the minimally invasive setting? What we prefer to do and what we have learned is we do the laparoscopic gastrectomy with the surgeon standing in between the split legs of the patient. The assistants can shuffle between right and left depending upon the pedicle you're going for. The monitor is at the head end and the trolley is at the right foot end of the patient. What we want to see is this right here. The clipped root of the right gastric artery over here, the 12A nodes going up, which have been taken. This is the gastroduodenal artery. The station 8A nodes gone, and this multiple clips on the left gastric artery pedicle at the celiac trunk. So the idea of showing this is that you need to replicate your technique that you're doing in your open surgery in the minimally invasive scenario. So those are the 11P nodes right up to the sphenic hilum. This is again a radical distal gastrectomy, laparoscopic, and the idea is to get a similar outcome as you're doing in your open surgical practice. Now, when we look at the history of minimally invasive surgery, first it was reported from Japan by Professor Kitano's group. They did a Billroth 1 reconstruction, laparoscopy assisted. Then over the next 5 years, it got further evolved into a laparoscopic D2 gastrectomy. And Azagra and colleagues actually in 1999 described a laparoscope-assisted distal and total radical gastrectomy for locally advanced gastric cancer as well. In the early 2000s, Professor Giulianotti's group from Italy described the distal and total robotic radical gastrectomies. So these were the initial steps that actually told us that there was a proof of concept that these techniques could be used to deliver in these settings. And the minimally invasive techniques came with its usual benefits in the short term: low morbidity, early return to work, less requirement of post-op analgesia, less wound-related complications. The flip side in these was that there was a less lymph node retrieval and the operating times were longer. And obviously there was a selection bias. So the conundrum remained that how does it fare? How does minimally invasive surgery fare in an oncological setting? Because we need to deliver a safe and goal-directed treatment option because we're dealing with the cancer and its inherent challenges. And the priority is to deliver a safe procedure as well as an oncologically feasible procedure. And to answer these questions, good quality data focused on those was needed. And that is exactly what we have got over the past 2 decades. Now, we have already talked about the screening programs in Japan and Korea, and most of the data, actually more than 90% has come from there. So looking at the early Japanese data, Professor Katai and his group actually published in 2010. They looked at clinically stage 1 gastric cancer patients, 176 patients, and the idea was to assess safety of laparoscopic assisted distal gastrectomy plus a D1 plus nodal dissection. and they demonstrated the safety of the procedure in the short term. And in 2018, they also published the long-term results and demonstrating a excellent 5-year overall and recurrence-free survival of 98.2%. This was followed up by a more refined, the Japanese clinical oncology group by the same group, and they published the results in 2016. This was a multi-center phase 3 randomized controlled trial. They compared laparoscopic distal gastrectomy versus open against stage clinical 1A and 1B. They had 921 patients, and they reported similar recurrence-free and overall survival in both the groups. Now, keeping up with this trend, the Koreans stepped in with the excellent class 1 study from the Korean group. Professor Kim published in JAMA Oncology in 2019. This is a wonderful study that actually demonstrates safety of laparoscopic distal gastrectomy in early gastric cancer. They accrued 1,416 patients using 15 surgeons, 13 institutes. And when they published their short-term results, they demonstrated statistically significant differences in post-operative morbidity. As far as intra-abdominal complications were concerned, they did demonstrate lower number of intra-abdominal complications in the laparoscopic group, but it did not reach statistical significance. And when they published their long-term results in 2019, the overall survival and the cancer-specific survival almost mirrored each other. And they actually came out and said that when using for stage 1 distal gastric cancer, laparoscopic distal gastrectomy is associated with low morbidity and comparable survival to open, and it does not compromise the oncological outcomes in the long term. And this endorsed the view, and actually the Korean surgical guidelines endorsed laparoscopic distal gastrectomy as a standard treatment for stage 1 gastric cancer, obviously by surgeons with sufficient expertise. Now, they started to stretch their wings a little bit, and they said that what about the technically more demanding total gastrectomy with proximal lesions? Again, here we're talking about early gastric cancer. The part of the Korean class group was the O3 trial, and they published their results in 2019. They looked at laparoscopic total gastrectomy for early gastric cancer for feasibility. It was a single-arm prospective multicenter trial, and they demonstrated a post-operative complication rate of 20.6% and a mortality of 0.6. And when they compared it with their with the studies published in the open category, total gastrectomy was comparable. And another wonderful trial came from China, which again looked at total gastrectomy. It was a multi-center RCT. The Chinese class group, the O2 trial, published in 2020, they compared the safety of laparoscopic total gastrectomy and open total gastrectomy again for stage 1 gastric carcinoma. And all of these patients showed no significant difference in overall mortality and morbidity. And the post-operative complication rate was extremely comparable. And this study actually sort of solidified the idea that laparoscopic total gastrectomy with lymphadenectomy performed by experienced surgeons is as safe as open total gastrectomy. So we have spoken about early gastric cancer. So is the debate settled for it? Apparently for the Koreans and the Chinese and the Japanese it is. But what about advanced disease? The bulk of our cases. This is the Japanese laparoscopic surgical study group. They looked at 507 locally advanced gastric cancer patients. It was a multi-center open label trial, 37 centers. And they found out that the laparoscopic group had a longer operative time, but significantly lower median blood loss of 30 ml versus 141 ml, which was statistically significant. More importantly, they were able to show the non-inferiority of laparoscopic gastrectomy distal for advanced gastric carcinoma versus an open distal gastrectomy. And the overall survival data also supported the non-inferiority of laparoscopy in this group. Similar trial came from the Korean group, the O2, in the form of the O2 trial, and they looked at 1,050 locally advanced gastric cancers. They classified tumors from clinical stage T2 to T4A. The catch here was that there was a low nodal burden patients, and 37 centers randomized them, and they found out that the laparoscopic distal gastrectomy with D2 lymphadenectomy in locally advanced gastric cancer had lower rates of both early and late complications. And interestingly, the 3 years recurrence-free survival rate was almost mirroring each other, with 80.3% for lap-assisted and 81.3% for open distal gastrectomy. The trial that I liked the most among all of these actually came from China. That was the class 01 trial. This was the first in their class series of trials, and they actually started looking at advanced gastric cancers because the bulk of their cases are advanced cases. And they accrued 1,056 patients and they looked at clinical stage T2, 3, and T4A. They ruled out bulky nodes, and they actually defined these bulky nodes. They said that any nodal mass that was more than 3 centimeter will be excluded. They published the results in 2022. And when we looked at the survival rates over 60 months for all the stages, it is similar in both the groups, laparoscopic as well as open. And then stage-wise breakdown also showed that the outcomes mirrored one another for stage 1, stage 2, and stage 3. Now, the interesting part in this trial was that if they were reporting about locally advanced gastric cancer, why did they have TNM stage 1 disease, and they reported them in their findings? It was seen that in this study, a lot of cases were actually overstaged at the clinical time, at the clinical stage, and then they became part of the analysis. But notwithstanding that fact, when we looked at it individually at stage 2 and stage 3 patients, the outcomes were almost similar over 60 months. So it again proved oncological feasibility of the procedure. And they came out with this conclusion that when used for advanced gastric cancer, T2 to 4A with a low node burden, the laparoscopic modality is associated with no significant difference in overall 5-year survival versus open distal gastrectomy when performed by experienced surgeons at high volume centers. Now, this term experienced surgeons at high volume centers has come a number of times in all these studies. We need to understand that the identification of centers and surgeons in all of these trials was very stringent, and a lot of peer review and a lot of peer review was done in selecting which surgeon will be doing, which has at least a certain number of procedures under their belt and have a certain number of per annum cases attending the centers. Now, having looked at all this data, there are further questions that remain, especially in our settings and the Western setting. What about proximal tumors? And what about tumors that require neoadjuvant chemotherapy? So, looking at the data, there is still a lack of high quality data in clinical research, which focuses just on advanced upper and middle third gastric cancers. There is one trial from Netherlands, which had actually 227 patients, and out of which 102 of them were upper and middle third lesion patients. Across the board, they had anywhere from T1 to T4A and nodes anywhere from N0 to N3B. They showed there was no statistically significant difference in the 3-year prognosis, with the laparoscopic group again showing lower intraoperative blood loss. The Chinese, in their 04 iteration of the class trial, actually looked at proximal tumors with nodes in the splenic hilum, and they compared the conventional laparoscopic total gastrectomy with a variation known as a laparoscopic spleen-preserving total gastrectomy with splenic hilar lymphadenopathy. They actually showed the feasibility of this laparoscopic spleen-preserving total gastrectomy with splenic hilar lymphadenopathy. And it actually showed favorable long-term outcomes in advanced upper third gastric cancers. The Korean class 06 and the Chinese 07 trials are focused on locally advanced upper and middle third gastric cancer. They started accruing in 2017. They have published their short-term results, and unsurprisingly, the short-term results in the laparoscopic group have been seen to be beneficial. We still await their long-term results, but the expectation is that the long-term results will mirror what we have seen in the studies of the past between both of these groups. And the Chinese class 03 trial is planned to evaluate the safety of laparoscopic gastrectomy after neoadjuvant therapy. In these countries where they have a robust screening protocol for early gastric carcinoma, the question of quality of life actually emerged. Since they are doing laparoscopic gastrectomies for T1 disease or stage 1 diseases, they have looked at other function-preserving gastrectomies like pylorus-preserving gastrectomies, laparoscopic proximal gastrectomies, vagus-preserving gastrectomies. One such trial is the Korean class 04 trial, which looked at laparoscopic distal gastrectomy versus laparoscopic pylorus-preserving gastrectomy. They included stage 1 tumors which were at least 5 centimeters away from the pylorus and compared them with one another. And both of the procedures actually favored similar. The laparoscopic pylorus preserving group actually compared favorably with the laparoscopic distal gastrectomy group as far as quality of life is concerned. The overwhelming question was whether these patients would actually develop some amount of gastric stasis or gastric outlet obstruction. And it was seen that only 7.5% of the patients in the laparoscopic pylorus preserving group actually developed some amount of gastric stasis or gastric outlet obstruction, and none of them needed a reoperation. So this is where they have reached. They are preserving functions in early gastric carcinoma, and we are still looking at survival and diagnosis of patients before stage 3 and stage 4. So this is just a summary looking at the short-term oncological outcomes in the large randomized controlled trials. And this is in the advanced gastric cancer setting. A little briefly about robotic surgery, since we don't have much experience with it. It does seem that there is an inevitability about it. Why do I say that? It is because robot-assisted surgery has made significant incursion into various surgical specialties. And it emerged basically as if you want to call it limitations, as a solution to the limitations of laparoscopy. They mention 3D imaging, motion scaling, enhanced surgical field visualization, tremor filtering, precise alignment, and articulated wrist joint, and the 7 degrees of freedom as their USPs. And importantly, the design of the surgeon console helps us to sit comfortably, reduce discomfort, fatigue, and burnout during long procedures. And we should understand that with the availability of technology, and inevitability in application is obvious. Now, I know that the question of cost is there, the question of availability is there, but this is what the future holds for us. Robot-assisted surgery is here to stay, and we need to look at it critically, just as before with laparoscopy. We need to look at high-quality data on robot-assisted gastrectomy, and most of it has again come from the East. Ojima et al. Published a short-term outcome comparing this feasibility of robot-assisted gastrectomy versus lap-assisted gastrectomy in 2021. It was a phase 3 randomized trial, and they included, again, across the board stages 1, 2, 3. The primary endpoints were post-operative intra-abdominal complications, Clavin-Dindo grade 2 or higher. And in this, they concluded that basically robotic distal gastrectomy did not reduce intra-abdominal infectious complications compared to lap-assisted distal gastrectomy. However, studies from Korea and China also showed that both of them are comparable in the short term. And a large meta-analysis of 40 clinical studies involving around 17,700 patients found that robotic surgery had advantages like reduced bleeding, faster recovery, more lymph node dissection and harvesting, and a lower rates of surgical complications. They did report longer operative time and costs, that is there, and the long-term outcomes are still awaited. A recent study from China, which was published in May of 2024, this year only in Nature, actually changed this perspective a little bit. They evaluated a 3-year disease-free survival as a primary outcome, along with 3-year overall survival. What they found was that when they looked at patients with the T1 stage, the 3-year survival, the 3-year survival was almost mirroring the laparoscopic group. But when they extended it to higher stage groups, that is T2 to T4, they actually found that the robotic group was actually doing slightly, if not extremely better than the laparoscopic group. The story was repeated with the nodal burden. In N0 stage, again, the outcomes were mirroring the laparoscopic group. In a bulky nodal disease, again, the robotic group was doing slightly, if not extremely better than the laparoscopic group. When they did an analysis, they showed that overall in the disease-free survival, there was no significant difference at 1-year follow-up. But when they looked at years 1 to 3, the robotic distal gastrectomy showed a survival of 95.3%, and the lap distal gastrectomy showed survival of 83.9%. It did not reach the inferiority criteria for the study, but it is something to look at. Other studies, again, Professor Lee's group published in Surgical Endoscopy showed similar survival rates and recurrence patterns. What we can say is that by looking at this data, at least we can say that this data supports the safety and efficacy of robotic gastric cancer surgery, and further high quality studies are required to validate its presence and if it can actually replace laparoscopy in the near future. Now, when we are talking about minimally invasive surgery, there is a large number of armamentarium that is available to us. The ICG has been used in a number of surgery, biliary surgeries, liver resections, but the ICG near infrared imaging technology has shown promise in early gastric cancer as well as in locally advanced gastric cancer. The idea of laparoscopic sentinel node navigation surgery in early gastric cancer has resulted in a less traumatic surgery to the patient, not requiring an extensive lymph node dissection. In the Senorita trial, they actually published this in 2016 and showed the feasibility of using the laparoscopic sentinel lymph node navigation surgery in only harvesting the nodes that actually showed positive uptake. In advanced gastric cancer, this study from Japan actually showed that this technology was beneficial not as an early gastric cancer for identifying the nodes, but basically in harvesting a greater number of lymph nodes. In advanced gastric cancer, the extent of lymph node dissection was better by using ICG near infrared imaging technology with a greater number of lymph nodes harvested. Also, this technology has been used for GI anastomosis perfusion analysis. 3D cameras in minimally invasive surgery, that is 3D laparoscopy, has changed the idea about depth perception, but it is unclear in the data whether it actually offers a clear advantage in terms of lymph node dissection, operative time, and blood loss. What it does encourage is it shortens the learning curve in gastric cancer surgical training, especially facilitating precise and complex anatomic steps. Now, concluding with the boom of the AI, and AI and deep learning has found its roots in minimally invasive surgery as well, because AI-based deep learning technology has been integrated in minimally invasive surgery, and it has opened endless possibility in data analytics. This data gathered during procedures, it documents crucial anatomic steps with time and position of the instruments, intraoperative events during which anatomical stoppage happened, and it provides the surgeon with a new insight. And the AI and deep learning software actually uses this data to prepare an analysis of the surgeon performance, as well as an entirely database summary of the procedure, which can be used for self-technical standardization, that is self-improvement, as well as for teaching purposes. So the possibilities with AI and deep learning integrated with MIS are almost endless. So the messages that we would take to the OR with this data that we have looked at is that over the last 30 years, MIS for gastric cancer has made significant strides. It has proven itself to be safe and oncologically feasible in the right setting. Minimally invasive surgery for gastric cancer will soon become a mainstream modality with a good look at robotic surgery. And incorporation of imaging technology and data analytics gives a new dimension to minimally invasive surgery. But streamlining of training, vis-a-vis standardization of operative techniques and protocols, and establishment of high-volume centers with robust referrals is key. With this, I thank you all. Thank you, Kapoor sir. I would like to take comments and suggestions.
So before Das takes over, Hamza, two very short questions. One is, for the sake of students, please explain what do we mean by laparoscopic gastrectomy and laparoscopic assisted gastrectomy?
Yes, sir. So basically the term laparoscopic gastrectomy and laparoscopic assisted gastrectomy has been used interchangeably, although they are mutually exclusive as well. A laparoscopic assisted gastrectomy would entail a resection and a dissection, which is laparoscopic, and the reconstruction of the GI continuity is done extracorporeally. So that would entail a true laparoscopic assisted gastrectomy. Although in these studies the terms have been used interchangeably, true lap assisted gastrectomy would be restoration of GI continuity extracorporeally. And on the other side, if you would do an anastomosis inside and just remove the specimen, it would be a totally laparoscopic gastrectomy.
The second is more a comment, but you can respond to that. To the best of my understanding, I have no personal practical experience of robot, but after having read about it and seen some of my colleagues doing these procedures, I feel the biggest advantage of robot is where the anastomosis is difficult. Resection probably is same whether you do it laparoscopic or robotic. So I feel in a procedure like PD, where the pancreatic anastomosis is the precarious anastomosis, where you sometimes need different angles of movement of the wrist, probably robot will have an advantage. So in gastrectomy, the reconstruction is not a technically demanding part. So from that point of view, and of course considering the cost, what is your personal opinion after having read and reviewed this topic? In a country like ours, is robot going to play an important role in surgery of the stomach as compared to laparoscopy?
Sir, I would never say never, but the studies that I looked at for robotic surgery, actually it was the lymph node dissection that was the critical part, because the area we're dealing with, and if there is a bulky nodal disease, there is a locally advanced gastric cancer, and you need to get around those nooks and corners, the robot has actually facilitated greater amount of lymph node dissection. As Professor Dash was mentioning initially, that the lymphovascular component of the lymph nodes needs to be taken, and we need to get it right at the pedicle. So in those scenarios, the robot has actually shown a greater number of lymph nodes. Whether harvesting 40 nodes and 45 nodes actually makes a difference in the survival needs to be seen. It's actually a question of stage migration over there. But most of the studies actually mention this only. And some studies have actually shown an earlier return to work. Maybe minimal, but actually an earlier return to work in the robotic group. So it needs to be seen, sir. Obviously, in a country like ours, where we have a lot of cost restraints, till it comes to the public sector, the robot will not truly be assessed.
Das, please carry on.
So that was, thank you, Hamza, and that was a very extensive coverage of the evidences that are comparing the open versus laparoscopy or the minimal invasive. I'm not very sure whether you using a hand port would be a pure laparoscopic or a laparoscopic assisted. Some say that using a hand port would be a pure laparoscopic, which I really do not agree, because if you combine all the incisions, it is more than the midline incision that we use for stomach, particularly for stomach. And regarding the robots, if I may be allowed to comment on it personally, then I have looked at the evidences, I've used it, I've seen it, and till now, barring urologic ones, I'm not discussing about the pancreatic ones. So far as the stomach part is concerned, it is only helping the surgeons nowadays. How far it would help the patient economically and functionally and all those is yet to be seen. And a lot of senior people, when we discuss, they have also casted similar doubts as I am asking, as I'm suggesting. Now, there's a very interesting observation. If you see the trials regarding the benign conditions in which laparoscopy versus open is the comparison there versus the malignancies. It started with benigns, and it was in the benign conditions, it was mostly the functional aspects of the laparoscopy they were highlighted and shown to be much better. If you see, you can see your trials which you mentioned and in the literature, the trials of last 5 years are mostly focusing on the oncological advantage of laparoscopy, non-inferiority of the laparoscopy over the open in the oncological outcome. So they are saying that the oncological outcome is not inferior to open. Now, very few trials and really exhaustively taken into account the functional aspect of the laparoscopy. That the early discharge, the going back to functions, particularly in advanced advanced stages of cancers where laparoscopic is done. So I am quite hopeful that a lot of these trials are coming up. We'll be getting the results by the end of 24 or early 25, where this thing need to be discussed. That we have no doubt that laparoscopy is not inferior to open so far as the oncological outcome is concerned, but we have to add the functional part and then say that yes, laparoscopy is really superior to open if we combine all these things. Now, tomorrow we will be discussing all these things again, most probably. We have this overview of management, we have these lymphadenectomies techniques, we have these lap assisted techniques in 3 talks. So I'm not going towards the theoretical part of it or the evidence part of it. Let's little bit focus on the technical part of it, so far the minimal invasive part is concerned. Now, laparoscopy theoretically, if suppose I am going for a gastrectomy, I am feeling the stomach by the instruments. I am losing the tactile part of it. How do I decide that the margin of resection of the stomach in laparoscopy, particularly in small tumors?
Yes, sir. This question has been quite researched and most of the people who are doing these laparoscopic gastric resections, especially in early tumors, like you said, if there's a small lesion, they take the help of an intraoperative endoscope actually to confirm the resection margin. And in most of these patients, the distal margin is never a problem. It is always a proximal margin that creates some sort of a problem. Another solution would be a preoperative tattooing of the tumor itself. That is also one way, but nothing beats an intraoperative endoscopy. Before you actually go for a resection, you confirm on endoscopy a clear margin, and then depending upon the functional outcomes that you want, you can extend your resection as and when is required.
So we have a convention to start at 7 and finish at 9. So we have another 7 minutes.
So Dr. Rao wants to say.
Yeah, maybe you can invite brief comments from other panelists. Rao, yeah, Subramanian.
Yes, sir. I think about the lesion localization and the proximal margin. Hamza has actually told us in most situations it's not very difficult, at least in an Indian context, because the tumors are already visible. But the smaller ones, I think the best solution is to do an intraop endoscopy. And if you are an endoscopist, it's always an advantage. Seniors like Kapoor sir have always told us surgeon has to be an endoscopist. Surgeon was the first endoscopist and should continue to be an endoscopist. So best is to see it for yourself, not to believe anybody else as far as anatomy is concerned. If you want to be safe, and if your pathology report should speak about the character of yourself and your surgical resection. And sir, Dr. Dash, how many times would you actually palpate the stomach and understand the margin? Most of the time it is visual inspection, which actually tells you where you would resect. Palpation would not help except in the diffuse type of gastric cancers. So in open surgery also, a small lesion is not easy at all. A very small lesion is not easy even in open surgery. At least the margin is not easy. You may be able to feel the lesion, but the margin is decided by an endoscopy, even in open surgery. That's what we do. Even if you have to convert for some reason, because we are a very, very high volume minimal access center. We anastomose everything minimal access. So it's not lap assisted, but it is laparoscopic, complete laparoscopic resections. We also do some robotics. For finance are the only constraint. So this problem is extremely rare. It does happen, but it's rare, and we do an endoscopy. We do an on-table endoscopy. Our threshold to do an endoscopy is very, very low, sir.
What about endoscopic tattooing just the day before or on the morning of surgery?
Tattooing is something that we attempted. Surprisingly, I don't know. India ink is something that is not consistently available. You call it India ink, but it is not available in India itself, sir. I don't know.
Yeah. I agree.
Because it is used during elections.
We don't find it here.
Yes,
This
sir.
is what Dr. Ramesh Adnari told me. It is not available in the market because it is used for marking the finger during the elections.
Oh, really, sir? That is good information.
I learned this from Ramesh Adnari.
We are learning more than science now, actually, from sir.
So just
Dr. Rao, how do you decide the margin then? That's for the students.
It's endoscopic assessment, sir. Pre-op endoscopic assessment.
How far from the margin, and how are you sure that it's not extending histologically?
Depends on the morphology and the histology, sir. If it's poorly differentiated, if it's a diffuse type, we prefer a total gastrectomy in most of the patients. Otherwise, it's 3 versus 5 centimeters. Depends if it's poorly differentiated, it's 5 centimeters.
So if we are doing a partial gastrectomy, if by definition, if we go by D2 gastrectomy, it would be subtotal or total. But if we suppose we are going by 5 or 3 centimeter, is it advisable to go for margin frozen section?
How much margin can you do frozen section, sir? It's such a long margin. So frozen section is not a very good idea, especially in stomach. And you have a strip of tissue. It may not always indicate what it do. So I think what you mentioned, made a passing mention that a subtotal gastrectomy and a total gastrectomy is not a bad idea at all, sir. if you have in doubt, I think subtotal gastrectomy is a wonderful procedure. The rest of the stomach dilates well, although metabolically it may not be as good as a partial gastrectomy, but in cancer, I think subtotal gastrectomy, total gastrectomy should be the procedures.
Like in rectum, can you
Yes.
reduce the margin if you have used neoadjuvant treatment?
Nobody knows, sir. We don't know the answer because nobody tested this, because the sensitivity of the margin, the preservation of the mucosa of the rectum is much higher, because stoma or no stoma is a very serious consideration. In stomach, you remove 1 more centimeter, patient would never even realize, and it would not hurt you also, because stomach really expands. And a centimeter more is not a problem here. Centimeter more is a serious problem in rectum. So there we could test it. Here, I don't know how ethical it will be to give a smaller margin and try.
And for the benefit of students, can one of you quickly explain what is quasi-total or near-total gastrectomy? Because this question we often ask them.
I won't be the right person to Hamza? Sir himself should answer this probably.
Sir, I think it has been part of. Am I audible, sir?
Yes, yes.
You are
Yes,
audible.
yes.
This has been part of conventional teaching, near total, quasi total gastrectomy. But what we have found out, especially in cancer, it is subtotal or total gastrectomy now, sir.
That's what
Sir, I would say quasi, actually, if you literally use it, it is less than total. So less than total means it would be a distal gastrectomy. That is not quasi. Quasi means it's just sort of total. That's about what you can say near total. Earlier on, we used to say 95%, then used to say partial, they used to use percentage. So it's a, if you leave the fundus of the stomach, part of fundus of the stomach, you would say that it would be quasi.
So it's 9. I think we will have to close. As I said, we start on time and finish on time. We will continue the discussions tomorrow. I hope all the panelists will join tomorrow also.
Yes, sir.
Yes,
And,
yes, yes.
so specifically, first, I would like to thank Das for agreeing to moderate today's session. I would like to thank Dr. Aimon from Myanmar, who accepted our invitation to be on the panel, and all the other speakers, and Sadaf and Anushri, who are actually the panelists tomorrow, but they joined today also, and Subramanyeshwar also. And we will meet again tomorrow at 7 p.m. Tomorrow's session will be moderated by Dr. Vikram Kate, who is the Professor of Surgery at Jaipur, Pondicherry. So, thank you, everyone.
Thank you,
Thank
sir.
you, sir. Thank you.
Good night, sir. Good night, sir.
Good night, sir.
Thank you.
Thanks to the technical team in Ahmedabad. Thank you.